out there can see what I'm going to talk about. I wanted to give you guys an update in 2025. There's a lot of exciting things that's been going on in our field for the last year or two, and I wanted to share with you some of our experiences and what's new and exciting for us. So no disclosures other than that we're going to be talking a little bit off-label uses of some of these vasodilator therapies, which are, as you know, just approved for group 1 disease. We'll illustrate a couple cases of why I think that's problematic. So a couple of the objectives that I hope to accomplish today is just to be aware of the new hemodynamic classifications of pH, and then try to understand how we approach every individualized patient and the problematic issues with just having a strict protocol and putting patients into categories, and then to be able to apply our newer risk scores and then understanding how newer agents fall into this algorithm that we have. So I'd like to start with a clinical vignette, kind of a softball, 66-year-old with a history of scleroderma, Raynaud's, coming into to the rheumatology clinic with worsening exercise symptoms, and referred to us by Rue to show you her EKG, which is notable for a right axis, but otherwise looks okay. Her echo actually also was read as quite normal. So we'll get back to this case towards the end of the talk, but I want to kind of go through how we approach this. In reality, looking at the 2D, I apologize, I didn't get the moving parts here, but the RV probably is a little slightly dilated, but for what it's worth, it was read as normal. So we have a couple options of either stopping here or, kind of pursuing this further. And we'll hopefully by the end of the talk, when we come back to this case, we'll be able to understand the kind of thinking behind this. Okay, so the World Health Symposium is the major group that basically meets every couple of years to classify and characterize this disease. They first started in 1970, I believe, and since then, it's been ongoing as a kind of way to refine, add the evidence to the current guidelines. And the big kind of shakeup here was that the mean PA definition now of pulmonary hypertension and is a mean PA of over 20. So there's a couple categories here, hemodynamic categories. When we say pH, all we're meaning is that the mean PA is over 20. It doesn't really give no cause, etiology, anything like that, but we know that there's an elevation in mean PA pressures. Mean precapillary pH is a very specific entity that is described by a mean PA of over 20, a wedge of under 15, and a pulmonary vascular resistance of greater than 2 Wood units. So this is new from the past 40 years of us doing this, is that there's a lower limit here of a mean PA being 20 rather than 25. So that's the kind of the big change here. Isolated post-capillary hypertension is the scenario of left heart failure, where you have a mean PA of over 20, a wedge of over 15, but the pulmonary vascular resistance is still low. There's no remodeling of the lungs. This is all just directly from the left side. Contrast that with combined pre and post pulmonary capillary hypertension, where your mean PA is over 20, wedge is over 15, but your PVR is over 2. This is a very difficult phenotype to deal with because there's kind of a mixed physiology going on. And the final new element here, exercise pH, was absent from these hemodynamic criteria for many years, and incorporating newer evidence with exercise studies, this new definition of exercise pH with the recognition that some autoimmune patients, this is the early manifestation of fixed pH, is that the mean PA over cardiac output slope is over 3. So how do you do this? It's possible. You need a exercise bike in the cath lab, you need continuous cardiac output, and you need fancy software to do this. So it's not very practical to do yet, but it is in the definition that if you have access to one of these labs, this might be a important entity to pick up during routine right heart catheterization. But those are really the two big changes from the last 40 years of hemodynamic definition of pulmonary hypertension. So if we think about where did this, historical mean PA of 25 come from, I made allusion to this first WHO meeting back in 1970. 17 people sitting in a room. This was expert consensus, and the other important thing that came out of this in 1973 was the establishment of this registry, this North American registry, is the NIH registry, that gave us a lot of insight into what the disease was, how prevalent what it was, and the average, and they had about 160 patients in this study when they finally published about 10 years later, the initial registry data. Mean PA was 60, average survival was 2.3 years. So it was a highly, fatal disease at that point. But the bottom line is this was expert consensus. Nobody really knew what the mean PA should be, but 25 sounded like a good number for these 17 people sitting in the room. So since then, thankfully, we have a lot more data to support these recommendations. So this is a large review that was done in 2009. I don't know how they got 1,187 normal people to volunteer for right heart caths with exercise, but so be it. They were able to get, a large cohort of normal people. And throughout all age groups, throughout all genders, it turns out that the average mean PA is about 14. So 2 standard deviations over 14 is roughly 20 millimeters of mercury. So this is the first piece of data that we say, okay, well, maybe 25 is a little too high here. So why would we even decrease the cutoff? Is there some prognostic reason to do that? Meaning, do they do worse? This was a circulation study in 2016 where they took US veterans. So again, a very kind of highly comorbid, uniform population, but 21,000 people, even after taking out the true pre-capillary people, which would be a higher risk, meaning the wedge over 15, which is also the post-capillary, and the PPRs over 3, which is the pre-capillary profile. Even after adjusting for that, mortality seemed to go up right around the 20 millimeter mark. So with that, this added to the evidence that perhaps a lower mean PA cutoff actually had prognostic information. Maybe that was, not appropriate to wait till 25. Again, caveat, this is the US veterans population. This is an older crowd, lots of cohorts. So finally, there is this large meta-analysis, which all of the problems with meta-analyses, but looking at right heart cath and echo data. This was published in 2018. And basically what came out as pretty consistent is that whether right heart cath or echo showed, demonstrated the mean PA over 20, it seemed to point to worse outcomes with even mild PH. So that was the rationale to say, well, perhaps that this, all this evidence, this wealth of evidence supports the finding that we should probably start paying attention at a mean PA of 20. Should we treat this? So that's really the issue here. So the increased incidence, there's a couple implications of this. One is that we're going to find a lot more PH patients. All our therapies, everything that we've studied, use the traditional old criteria, mean PA over 25. So we don't have data that treating at 20 makes a difference. So with all these caveats, what do we do with the mean PA of 20? Pay attention. Treatment is a little bit, controversial at this point, but perhaps in certain populations, we should. So the exception to this data is the scleroderma mixed connective tissue disease people who do a lot worse, whatever we do. And there is some data suggesting that using a lower mean PA and treating these people will actually lead to better outcomes. So that's kind of the only caveat now, but for what it is, I think trials forthcoming from now on will have that mean PA of 20 on the basis that it does matter, it does implicate worse prognosis, and we should be paying attention at an earlier time. So next I want to go to the wedge, and this is kind of the bane of our, in the heart failure lab, in the right heart cath lab of our existence, where the wedge could be very wide variety based on the phenotype here and the patient. So this is a good normal wedge. We like this. We like seeing this. This is beautiful. There's a C and a V wave, a slight V wave here, but not much respiratory variation. We can safely say the wedge is around 9 or 10. pretty good. Okay, so we're very confident with this, but I'll tell you, it almost never looks like that. Here's a more typical wedge waveform that we see, right? So it could be anywhere from 14, which is upper end, maybe a little diastology, all the way down here to 6. So the software interpreted it as 8. I would probably put it higher at end expiration, somewhere around 13, 14. That changes things when you're thinking about what's the etiology of pH, right? And then I want to talk about the V wave. We see this all the time. The V wave with MR, with diastology. Where do you put this wedge? If I call it 13, 14 down here with the C bump, which is where you're supposed to measure it, you're supposed to say the C wave or the peak and the trough of the A wave is where you're supposed to measure the wedge. The V wave shouldn't play much of a part into it. But if your mean PA is 35, 40, how can you say that it's not from left heart disease looking at this waveform, even if the wedge, the mean wedge, is about 13, 14? So the waveform is really important. And this would be interpreted to me, if I looked at this waveform, I would say this is probably diastology or severe MR or left-sided heart disease, whatever. But when I write the report, you're writing the mean PA is about 13, 14. Doesn't impress people, right? So I think there's problems with interpreting the wedge as a distinct number here. And of course, once in a while, we see wedge forms like this. What is that? And basically this is because a lot of times, and we've started to do this, is use 5 French catheters, very tiny catheters, to try to measure a downstream pressure. We get a lot of artifacts. So the wedge itself, there's an art to it. And I think that a wedge of 14 versus a wedge of 8 really matters when you're trying to distinguish the etiology of pulmonary hypertension. So I'd like to bring up the second kind of idea brought up at the 7th World Health Organization meeting, is that there is a zone of uncertainty here. So when you get a wedge pressure of under 12, you can say, all right, this looks like a pre-capillary profile. This is fine. I'm fairly certain of this. Anything over 18, you're like, great, diastology. This is, left-sided heart disease. I'm okay with this. But there is a zone in the 12 to 18 zone where you really need to correlate with the patient's clinical context. So we'll talk about, the potential ancillary data in a second, but they ended this editorial with this statement, which I think is really, important to think about, is that the wedge should always be interpreted in context of the entire clinical picture and reevaluated when incongruent. Agreeing that certain uncertainty exists, using the full range of our tools and avoiding a binary cutoff will lead to better care of our patients. So what is that potential ancillary data? Well, you have the clinical history. A 70-year-old diabetic hypertension lady with AFib is probably going to have HFpEF. So any history of pulmonary edema, pre-capillary patients don't get pulmonary edema. So you have to think about, the implications of that. There is a scoring system, the HFpEF scoring system, which I'll review in a second. We also have echo parameters, just the echo. If I don't see an enlarged left atrium, even if the wedge is 16, I'm going to say, is this truly diastology? LVH, of course, you can look for MRI findings and things like that. And then provocation challenges in the cath lab, which is really important when you have a low wedge and you're really suspicious of diastolic or left-sided disease. So what about in our PAH trials? If your wedge is 14, 15, are we really sure that this is PAH, or does it matter? Is the wedge appropriate to say under 15 is pre-capillary? So this was an analysis done of all the PH trials that had hemodynamic data. So these are all PAH patients, true pre-capillary patients. And they basically stratified outcomes based on wedge. And what they showed here, and this is 4,000 plus patients, that even at a higher wedge pressure, there was still a sustained benefit of PAH therapy, thus supporting the idea that we shouldn't change the wedge cutoff, but we should just be cautious when it's in that 12 to 18 range, because treating true pre-capillary patients, even with a higher wedge, is still inefficient, still led to better outcomes. So I think the wedge cutoff being 15 is appropriate, but it does involve a little bit of thought. So I wanted to talk a little bit about the HFpEF score. And most of you guys will do this in your heads and not really need an official scoring system, but they validated this risk score. And what it is it predicts the chance that a patient has diastolic heart failure or HFpEF, which is a very difficult diagnosis to make. So if you're heavy and you're hypertensive, you get 3 points right there. And hypertensive being on 2 or more antihypertensive medications. Atrial fibrillation gets you 3 points. Pulmonary hypertension, meaning your echo RVSP is over 35 is a point. If you're elderly, age over 60, you get a point. And if your filling pressure, your EDE prom, this is the only echo parameter on here, is over 9, then you get 1 point. And based on the amount of points you have, your probability of HFpEF goes up. So 0 to 2 points, that's probably not HFpEF. 5 to 9 points, most certainly is HFpEF. Again, there's always going to be people that are in this range, right? So what do you do with that? And I'll show you how clinically this came up recently for me, and this is how we think about the score. So Mrs. M is a 79-year-old hypertensive on 1 antihypertensive, obese, with normal EDE product, normal echo, right? So EF is fine. PASP is measured to be 55. Okay, and this is her. What's that?
3 points.
Yes, exactly. So we got 3 points here, right? So she's obese, PASP is 75, age, right? So actually I gave her 4. So heavy is 2 points, so 4 points, okay? So she's in that range where it's like, yeah, it's probably HFpEF, right? It's probably HFpEF, but she's coming to me very short of breath. HFpEF is like the worst diagnosis you can give somebody because you say, it's a stiff heart, I don't know what to do with this, we can't really help you. She's very short of breath on movement. I talked to her about, what's the next, how can we be sure? We all know that right heart cath is the gold standard. Do you really want to put an 80-year-old through a right heart cath? It's an informed decision. I don't offer it for a lot of people. So what I usually do is say, go on Jardiance, go on Entresto, see me. If you really want to know, we'll do it. She really wanted to know. Okay, so I don't want to advocate for doing right heart caths on patients that you really think have HFpEF, but there's an occasional person that says, you know what, whatever it is, just tell me, I want to know for sure. So here's her right heart cath data, and interestingly, we see a mean PA of 19, which is just that cutoff, right? The wedge is 8. Transpulmonary gradient is 11, PVR is low. It's like, what's the problem? Why are you so short of breath, right? So the hallmarks of HFpEF is really a shortness of breath on exertion. We do these fasting, starving patients, right? Overnight, the best volume status you'll ever find. And, they're generally, pretty dry at this point. So do I believe it? Not for a second. So I say, you know what? Poor nurse and Murthy are pushing this bike test over to the cath lab table. We hook her up to the bike and we say, well, let's see what happens. Right. So we're all short of breath in the room at this point. And so but again, all of this work to prove that, yeah, the wedge does go up to 18 on, 2-3 minutes of a supine bike test in the cath lab. So do you need to do this? No, but now I can tell her that, hey, listen, I think the more we do these studies, we learn a lot of important things about the physiology of HFpEF. And thinking about clinical trials in the future, this is going to be one of the, standard ways of proving HFpEF and probably should be necessary and inclusion in most of these HFpEF trials. We have a lot of, options for her beyond Jardiance. So, I think it's an important thing to do, but this is confirmatory evidence with the stamp on it. Okay, so again, we're very short of breath doing this. Do we have to do this? So this is an interesting study that was published about a month ago in the JHLT. And they took 619 patients with suspected pH just based on echo and things like that, and normal wedge pressure. And they said, at rest, and they did the right heart cath. And they did 2 things. One, they did a passive leg raise, and the other thing they did was exercise. And so the exercise patients who had an exercise wedge pressure go up to 25, they labeled them as HFpEF. And then they looked at what happened in those patients when you did the passive leg raise. So it turns out that if your wedge goes over 14 and you're under 60, that's HFpEF. Okay, that has a pretty good correlation to the exercise official HFpEF diagnosis. If your wedge is over 13 and you're over 60, that's HFpEF, and it has pretty good specificity for that. So what this kind of suggests is that maybe we don't have to do the exercise. A simple passive leg raise and seeing the wedge go up may be enough in certain patients if you really want to be able to unmask this. And again, this would only be relevant if you highly suspect HFpEF, yet their wedge pressure is low. And this is important because the wedge will dictate how you treat this patient, whether pre-capillary, post-capillary, that kind of thing. So this is, it may seem like a silly thing to do for a diagnosis that may not necessarily change, but I think in the future, HFpEF is going to be treated very differently. This is the kind of the Pandora's box where there's so many patients with HFpEF that we don't really know what to do with. There's a lot of buzz in this world about newer therapies and things like that. So I think this is a very important diagnosis to make. So think about the passive leg raise with the normal wedge. I want to kind of illustrate why this is important. It's a hemodynamic continuum, HFpEF. It's not just about elevated left atrial pressure. There is certainly in the early stages where just early hypertensive diabetics, high left atrial pressure, where you have an isolated post-capillary hemodynamic, and that's okay. We just decongest, we focus on that. But there is a point and a stage that where we see a lot of these patients that have some significant right heart predominant symptoms. They have ascites, they have diuretic resistance, they're quite debilitated. And this is when all the remodeling happens. Now, if you look at the later two portions of this continuum here, we have pulmonary venous and arteriolar remodeling. That looks pretty similar to PAH. This is what's happening in the veins, in the pulmonary veins of these HFpEF patients, and eventually it will pass on through the pulmonary arteries. You have pulmonary arteriopathy, RV, PAN coupling. This looks a lot like PAH. So there is and that's the combined pre and post capillary hemodynamics that we talked about, with a mean PA over 20, a PVR over 2, and a wedge over 15. So this is a very important phenotype that I think, one thing is to decongest, but another thing is perhaps this part needs to be treated. We'll talk about that later. So why am I talking about HFpEF so much? Because this is the common phenotype, not PAH. PAH is very rare, but this is what we see. And I think it's it would be remiss to just dismiss this and not really address this as well. So we can talk about the hemodynamic classifications, which we've done ad nauseum, but there's also a clinical classification that we should mention. So group 1, obviously this is the kind that we want to find, because this is the stuff that our therapies were made for. This is where the sildenafil, this is where all of that stuff works. So they're idiopathic. The most common that I see here is connective tissue disease. So this is the phenotype I want to find. It's only associated with this specific precapillary hemodynamic profile: normal wedge, elevated PVR, elevated mean PA. Think about group 2, left heart disease. We just kind of spoke about this, but this can be pre-capillary pH or post-capillary pH. You can describe this hemodynamically in 2 ways. Group 3 is associated with lung disease. This is the obesity, hypoventilation, high CO2 states. And fortunately, this could be anything. It can look like precapillary. If your CO2 is 90, it's going to look exactly like precapillary pulmonary hypertension. We'll try to treat it, and you will make the VQ mismatch worse. Patients get worse. So it's really kind of important not just to hang your hat on hemodynamics, but to put the clinical context in. So I write this just to say that we always think that the right heart cath is the gold standard in diagnosing this stuff. It's not. It's actually the whole picture here. So this group 3 can be anything. Group 4 is generally just precapillary pH. And then group 5, of course, as the wastebasket group, can be anything. And again, the big things that I see here is kidney disease in the pre-transplant crowd. So hemodynamic clinical classifications come together to kind of think about the way to proceed. Okay, this was a paper that I was fortunate enough to be a part of this year about risk stratification of pulmonary hypertension that came out in the JHLT. And how have our demographics changed over the years? I can tell you the NIH original data, it was a female predominant disease, which it still is. You know, it was 5-to-1 back then. Now, 60 to 80% of our PAH population are women. So this is a female disease. Older age is worse outcomes, most likely to comorbids and things like that. So it is a female disease, but if you're a male PAH, you're going to do worse. Okay, so it's the few things in medicine where we females have an advantage. So male over 60 years, higher mortality, and then systemic sclerosis, so scleroderma, higher mortality. So this holds pretty much true since the 1981 data from the NIH, except now we're starting to see that it's a lot more females than we had thought. What are the types that we see in North America? Most are idiopathic and connective tissue disease patients. A few are congenital and drugs. So the big drugs that kind of sparked this whole revolution are the diet pills, the Aminorex, the fen in the 90s. Now it's mostly methamphetamines out west. It's probably the most common cause out there. Not so much here. Cocaine can do this, but those are the big drugs that we see. And then a lot of newer monoclonal antibody therapies, cancer therapies. Think about heritable. Gotten a lot of press. This whole BMPR2 thing. I think I don't see too much of that, but it is still 10% of our cases here. So we do the math. 340 million people in the U.S. and something like 400 something million people in North America. We say 15 to 50 cases per million, which will come out to about 10 to 30,000 patients in North America. So a lot, I would think so, and I think that in areas like the Bronx, where there's a lot of mixed connective tissue disease here, this is something that we see. Maybe it's not so rare. Certainly doesn't seem that way from my clinic. Okay, so we've got to be doing better with prognosis. So thinking again, NIH, the average, the median survival was 2.8 years. At 3 years, 45% of patients were dead. So that was back in the 1980s. Now 3 years survival, about 80%. So we think we're better, but really it has to do more with risk rather than actual overall all comers. So what we've learned is that risk calculators and risk scores really matter. So low risk patients, yeah, we can be pretty confident that they do pretty well at 3 years. The survival is upwards of 90%. But high risk patients, depending on which risk score you use, are seeing upwards of 50% mortality at 3 years. So again, despite the last 40 years of vasodilator therapy in the modern era, our survival in the high risk population is still quite poor. So we published this a couple of years ago about, looking into a deep dive on the risk scores. The most common risk score used is the ERS and the ESC guidelines. That's this over here on the my left here. And basically, patients are separated into 3 different categories. Low risk, your 1 year mortality is under 5%. High risk, your 1 year mortality is greater than 10%. Or just take a look and see what these categories are. The risk is basically all about RV function. That's really what determines the risk. So we have some clinical markers of RV failure. So there's right heart failure, progression of symptoms, syncope. All of these things are just clinical syndromes here. Then we have some functional parameters with WHO functional class, 6-minute walk distance, and then CPET testing. We have some lab work with the BNP, and then imaging, focusing more on the right atrial size and the presence or absence of pericardial effusion. And then we have the hemodynamics. note here that the mean PA is not included in the hemodynamic. So the risk is really RA pressure and cardiac output or index. So that's, the mean PA elevation has never been correlated to worse outcomes. So this is a fairly bulky risk score to use and not validated prospectively. You're not going to be doing CPET testing on all these patients. So it's not as practical as the REVEAL score, which is a North American prospectively validated risk score that we use here. And it's easy. You can do this at every clinic visit and assign a patient a score of, you're either in the green, which is low risk, intermediate, or high risk. And again, looking at the subcategories here, we have some non-modifiable risk factors, which are the WHO subgroup, the demographics, and comorbidities. You can't really change that. So these are non-modifiable risk factors. Connective tissue disease patients get an extra point. Portal pulmonary hypertension and heritable get an extra point. The males get an extra point. The comorbidities are really just creatinine, renal function. And then we have some functional parameters, right? WHO functional class, and then vital signs, which is systolic blood pressure under 110, pulse over 96. So all of these things are just markers of decompensated RV. That's, if you think about it, that's all this is. Any hospitalizations, 6-minute walk tests, which we do every 3 months in our clinic, BNP, easily obtainable, pericardial effusion on echo, DLCO under 40 on pulmonary function tests is important. The typical spirometry of a PAH patient is completely normal, but they have a decreased DLCO, and that's kind of the profile we're looking for. And then right heart catheterization, the only parameters that make it into this risk score is a mean RA of over 20 in the last year, or PVR under 5 will actually detract points. So this is an easy calculator. You can do it, they have these MedCal calculators here. You don't have to think too much. And you put the risk score on as either low risk, if it's under 6 to 9 is intermediate risk, over 9 is high risk. So this is really important. Every time the patient comes in, we establish what's your risk score, what was it last time, is it getting better, or how are we doing? So triple therapy in PH, so we have a triple therapy too. Triple therapy for me don't involve ACE inhibitors and things like that, but here's what we're talking about. Traditionally, for 30 years, all we talked about were these 3 pathways: endothelin, the nitric oxide, and the prostacyclin pathways. And I want to take a minute to talk about the histology, and this is kind of what we're targeting here. So we have a normal pulmonary artery with the 4 layers, very thin layers. And once we have this PAH profile, what happens is you start to get smooth muscle hypertrophy. This is a big deal. You also have endothelial hyperplasia, and then lots of fibrosis. And then these plexiform lesions are basically the lungs' way of responding to less oxygen by kind of forming these webs. So it's a lot of remodeling that's happening. So what do these 3 pathways do? Well, they all work pretty much the same end result. So whether you're doing an endothelin, nitric oxide, or prostacyclin, the end result is more cyclic AMP. Okay? They all work the same way through various mechanisms to increase cyclic AMP, and that causes smooth muscle relaxation. The smooth muscles look like this, basically. So these hypertrophied smooth muscles, you're just trying to relax them and open up the lumen a little bit. So we're not dealing with any of the real mechanisms of PAH, which is fibrosis, which is all this remodeling, which is all this inflammation. You're not really doing that with all of these therapies. We're just trying to increase the lumen size. So that's been kind of the Achilles heel up to 2024. This is all we've had, one of these 3. We can get fancy and pick 2, pick 1, and we kind of escalate as we need. But none of them really deal with the underlying pathophysiology of the disease. That being said, after I just kind of threw them under the bus, epoprostenol, which is a prostacyclin, an endogenous prostacyclin, is still the only drug that we have any kind of mortality data. This is, I show this all the time, 1996 is the only study, really. But this was a randomized trial of IV epoprostenol and conventional therapy, which at that time was diuretics, Joxin, and things like that. And 40 patients in each arm at 12 weeks, 100% were alive on IV prostacyclins versus 80% on conventional therapy. So this was it. This was New England Journal. This got epoprostenol approved. This is the first drug for PH, and it still is the only drug with mortality data over the years. So what's the problem? Why is everybody not on it? There's prostacyclin receptors throughout your whole body. So it is a horrible drug in the sense that you have jaw pain, you have nausea, you have muscle pain. It's a very difficult drug for patients to take. So they really have to be that high risk profile before I put them down this road, because nobody likes me after that. Nobody wants to come back. So I think this is a really important drug to have in your back pocket. This is one that works quickly, that works acutely. Within 3 months, we saw, these curves, if it's 40 patients, but they separated rather early. So that you see an acute, immediate vasodilatory effect of epoprostenol. It's a wonderful drug to start acutely in really sick RV patients. But it's got a lot of problems. So again, I put this on there, pre-2015, all of these drugs fit into one neat category, either your nitric oxide, your prostacyclin, or ERA, but we know now that the end result was all the same. You just kind of vasodilate these very dysfunctional fibrotic lumens. So let's talk about Sotatercept, which has obviously been the biggest kind of landmark thing in the last year or so. So how does it work? I mean, it took about 7 or 8 different times of hearing this before you kind of understand the complex physiology of how this works. But there is a pro-proliferative and an anti-proliferative signaling in the pulmonary arteries. So these BMPs, they're green because they're good. They actually cause anti-proliferation, meaning they cause apoptosis. But there's not that many of them. In PAH, there's a lot of these activins, which basically are the hypertrophy signal. They basically cause hypertrophy of the pulmonary arteries. So what Sotatercept does is it binds these activins, acts as a ligand trap, and blocks this proliferative signal. So now these BMPR2s can actually do their thing and cause apoptosis. So it basically shrinks down the pulmonary artery, makes them look more normal, gets rid of that pro-proliferative signaling, and the arteries start to look actually like normal pulmonary arteries. Very exciting, because this is not vasodilation, this is remodeling. So we think about this as a remodeling agent, and this was kind of 20 years of original basic science for this. So in 2021, the phase 2 trial came out, the Pulsar trial, and it was 30 patients in each arm. These are how big our PAH trials are. They're not very big. So what they showed is that at 0.7 milligrams per kilogram of Sotatercept, which is a sub-Q shot every 3 weeks, that you were able to show a decrease in PVR of 3 Wood units, which is big, at 12 weeks. At 24 weeks. So, and again, similarly, the 6-minute walk and other secondary parameters were also improved. So these were really good, well-treated patients, very sick population. 40% were on IV prostacyclins already, 60% were on triple therapy. So it was a very well-treated, sick group. Despite that, you were able to show a meaningful improvement in PVR. So this led way to the phase 3 trial. All of these things were in the New England Journal. It's just, they stuck to one journal. So this is the phase 3 trial, and this is the Stellar trial. And basically showed similar things. You see that the curves separate, somewhere around 15 weeks or so. And Sotatercept arm had greater event-free survival, as well as an improvement in 6-minute walk test. So what's the deal with the 6-minute walk? Like, that's just been the metric that we've always used for PAH trials. It's a little bit flawed, but it's something that you can easily kind of get objective data on symptomatic improvement. I'll tell you the PDE5 inhibitors, so sildenafil, tadalafil, all of that stuff showed an average of 20 meters more on a 6-minute walk test around 12 weeks. So this is significant in our world as far as, 6-minute walk improvement. But what's really, kind of intriguing is this kind of early separation and sustained separation in the Sotatercept arm. So this year, there was two additional publications in the New England Journal, the Zenith trial and the Hyperion trial. So the Zenith trial, what they did is they took patients, functional class 4, really sick, on, almost dying patients, and they gave them Sotatercept, and they showed that death on transplant significantly improved. Again, this was stopped early due to loss of equipoise. And the Hyperion trial looked at patients that were newly diagnosed, early therapy in naive patients, including PDE5 inhibitor, ERA, Sotatercept right off the bat. And again, stopped early because it was just overwhelmingly positive. So again, the data is mounting. Have we won? We're much closer. I'll tell you that from 2024 onwards. So again, same trial, same kind of graphs, and it takes about 10 weeks to see the curve separate here. So again, reinforcing the remodeling thing. When we first started using this, we saw something very kind of interesting. And I guess we'll talk about the safety profile too, because this is the big thing. The Achilles heel I mentioned with the prostacyclins, it's terrible. It's a terrible drug. But what about this? Nobody really feels it, So 24% in the Stellar trial had a headache compared to 17. So one can argue it's maybe not so much of a big deal. Epistaxis does happen. Gum bleeding when they brush their teeth does happen. Big deal. Usually people, they don't need to seek care for it. The thing that I'm seeing a couple times now, and especially in the mixed connective tissue disease patients, are telangiectasias, worsening of these facial things. This aesthetic, what does it mean? Why does it happen? Not entirely sure, but we see increased number of telangiectasias. Increased hemoglobin, 53% of patients. So Sotatercept was originally studied for thalassemia to increase your hemoglobin. The other interesting part that Sotatercept does is that it blocks the checkpoint for erythropoiesis. So usually there's a checkpoint that says, don't produce any red blood cells. So it blocks that. So now there's unregulated erythropoiesis. So it certainly increases your hemoglobin. Not a bad thing with thalassemia. And I honestly, most of my patients start off with hemoglobins of 9. So at roughly around 4 grams per deciliter people. So it's quite a good agent to increase your hemoglobin. That being said, we've not seen thrombotic events with this drug. So, and then a rarer thing that will cause us to pause therapy is thrombocytopenia, where you see platelets counts drop to under 50,000, you have to hold the dose. Unclear why this happens, but there is some hematological implications of this disease that we don't quite understand yet. But I have to say, overall, very well tolerated. It's not like people come in saying they're bleeding or bruising. It's mostly that we check blood work every 3 weeks on these patients for the first 5 months. So it's a little bit onerous, and it's a sub-Q shot, so that's site pain and things like that. But overall, compared to all our other therapies, it's very well tolerated. So how do we do this? How do we integrate this? So if you are low risk, and again, we meet the patient, we put them in the risk category, we've established a diagnosis of PAH. If you're low risk, I always just still start with a PDE5 inhibitor ERA. That's just our standard of care. That's what we've been doing. And I have to say, most people are okay with that. Repeat risk assessment every 3 months. If they're still low risk, no change. If they're intermediate risk, PDE5 inhibitor, ERA, we see them a little bit more frequently. Repeat the risk score. If they're low risk, no change, which a lot of people do. They get benefit from these things. If they're persistent intermediate, this is when I think about Sotatercept, rather than adding a prostacyclin. Okay, so I'll say that the oral prostacyclins, we have a lot of kind of formulations of prostacyclins. They just don't have the data behind them, so I've almost abandoned using oral prostacyclins altogether. If I need a third agent, it's usually Sotatercept at this point, and I think we have enough data to support that. If they're high risk, the answer is still IV prostacyclins, meaning if they're really very sick, we don't wait. But at the same time, getting that quad therapy set up. So it's approval for the PDE5 inhibitor, the ERA, and then Sotatercept as quad therapy. All right, so last couple minutes here, I want to end with our case. So 66-year-old, we talked about her normal echo, fairly normal, presenting with worsening dyspnea and exertion, referred to us by rheumatology. So we have some pertinent ancillary data, and again, I'm building the risk score here, right? So normal spirometry, DLCO decreased 48%, 6-minute walk, fairly poor. Hopefully everybody in here is 6-minute walk over 600 meters. So this is pretty bad. CT scan doesn't have any evidence of ILD, which is important when you think about shortness of breath and a normal echo. I want to make sure there's no actual ILD there. And then the BNP is slightly elevated at 108. No real TR velocity. Sorry, wrong way. So again, normal. So high risk group, I still offer it. Echo doesn't make sense. Everything else does, right? So, and I have to say that an important point about this is that we always used to teach that the echo is the gold standard, a good screening tool. And for the most part it is, but if it doesn't fit with the clinical scenario, I have at least 1 or 2 cases a year where it's completely normal echo, and I'm very surprised to see the hemodynamics look like this. So the echo is not perfect. And then, we should be interpreting everything as a whole picture here. So with her, high risk group, mean PA 38, wedge of 12, PVR is 5.9, very straightforward pre-capillary. No real risk factors for HFpEF, because I'm thinking about that with our zone of uncertainty here. But this would seem to me as a high risk group, mixed connective tissue disease, PVR is elevated. So what do? We plug her into the risk calculator. She's intermediate risk. So PD5 inhibitor, ERA, and then I start the Sotatercept process. Why? Because she's a high risk group. I know that regardless of therapy, the scleroderma profile is bad and tends to be extremely aggressive. So softball, this is the easy case, right? We kind of have a clear idea, protocolized, we can put her in a box, we can figure this out. But it's never that easy. So I want to switch to a more kind of complicated case here. So we have a 59-year-old guy. So he's a man, wrong gender for this, I should say. So the TIA he had a TIA in 1999, hypertension since 2001, and paroxysmal AFib, obesity, CKD. Okay, this is HFpEF, Murthy. What are we talking about? This is totally HFpEF, all the risk factors. I don't even have to plug him into the score, but I will just for fun here. He has an echo. I'm sorry this doesn't play, but basically large biatrial enlargement, small kind of restrictive looking heart. By the way, we did an MRI and amyloid and all of that, so it's not that, but something we should think about, but it certainly doesn't strike me as PAH. And again, thick heart, right? We can all agree that there's LDH here. Look at his PA pressures. It's a little bit out of proportion, right? We're getting a PASP of somewhere around 100 here, right? So the TR velocity is quite high, anywhere from 4 to 5. So a little bit out of proportion. So again, severe pulmonary hypertension in a guy that's long-standing hypertension. Okay, 99.7 HFpEF, right? That's his score, right? So, sorry, I keep going the wrong way. Okay, Entresto, Jardiance, Ozempic, right heart cath, in that order, okay? So here we are, baseline blood pressure is reasonable, RA of 20, PA 110/30 with a mean of 57, wedge of 22, transplant gradient 35, PVR 5.2. What is this? Okay. This is combined pre and post pulmonary hypertension. And I think about this. I think about this whole part of the cascade where we have right heart predominant symptoms. It's very symptomatic. Okay. And so there's a lot of remodeling here. I imagine this is looking very much like the PAH profile. And we think a little bit outside the box here, like what can we do to make this better in a 59-year-old guy? CardioMEMS is an important tool in heart failure. And basically it's a PA sensor device that's implanted. And it's used really to try to keep people out of the hospital. You follow their diastolic pressures, and we're able to kind of tell the patients, take more diuretic, take less diuretic, your wedge is going up, that kind of thing. And the idea is that the wedge grows up about 3 days before symptoms start. So this makes sense to kind of put in and have a willing patients who's going to play along. And so Dr. Shin does all of these cardiomems, and within 20 minutes, patients love it. They go home with this pillow system, and they transmit through a website, and we're able to get PA pressures. This was his on the day of implant, correlated very well to his actual pressures, right? So we're looking at pressures of 100/22. Okay. So what we need on this guy is systemic and pulmonary vasodilation. Propranolol is really good at that. It's like nipride. It does everything, right? So IV EPO is initiated in the hospital. Is this out of the box? Yes, because this is not PAH. I know that. You know that. But we need some kind of systemic vasodilation and pulmonary vasodilation. And so I don't need a lot of epoprostenol to the point where he's in pain. So we put him on low dose, leaves the hospital, and these are his PA pressures. Okay, we're getting somewhere, 77/3. And by the way, now he's off of most of his antihypertensives, except for Entresto and Jardiance. And he's doing okay, just not great. So what about treating this part of it? You know, the PVR of 5.9. How about treating the remodeling part of it? Increasing true, you know, if you put them on sildenafil, if you put them on any of these true isolated pulmonary vasodilators, I worry about this wedge pressure going up. He's diastolic, you know, sure. So Sotatercept kind of gets around that. It's a remodeling agent. It's not a vasodilator. So that's what we did. To target that part of this. And epoprostenol, Sotatercept, Jardiance, acceptable, right? A mean PA of 28, he's not going to feel that. And his mean PA, again, started off at 60. So these are kind of a more complicated cases where you think about, well, he doesn't fit into a neat box, but it's using the hemodynamic phenotype plus the clinical scenario to try to come up with a combination that can make this guy feel good. He feels awesome. And his, you know, torsemide dosing went down. He doesn't need so much diuretic. I think this is, you know, this is working for him, and how long to keep a 59-year-old on IV epoprostenol is really the next step here. So what have we learned? We have about, you know, I would say 50 to 60 patients on Sotatercept now. And this is, we just published this in the JHLT, it's in press, but this is our first 6 patients that had cardiomems and Sotatercept initiation. What's really interesting here, and this is the first time it was ever reported, is from Montefiore, is that this mean PA starts to come down within week 1. That's not a remodeling agent. That's something else, right? The remodeling part of this should take a month to come down. But what we started seeing consistently is that, and by the way, no background therapy has changed at this point, but within the first week, we started to see 45, 40, oh my gosh, like at 2 weeks, we're really down here to week 12, we're essentially normal, right? So there's likely a mechanism of this drug that we don't quite understand, because you can't say remodeling does this. It should take a little bit more time than that. So again, really important stuff here. So final thoughts, I'll let you go with this, is that it's complicated, almost possible to protocolize, and every patient should be kind of thought about in their individual clinical scenario. Group 1 has a lot of treatment options now. We're in a much better spot than we were 2 years ago. Group 2 is kind of the next big frontier here. This is the combined pre and post. Pulmonary hypertension still lacks effective therapies, but we're looking at several novel stuff. They're looking at Sotatercept for HFpEF, remodeled HFpEF, of course, and then shunt therapies. We're hopefully going to be part of a phase 1b trial with a systemic vasodilator for this. We didn't really talk about lung transplant here. I have to say I've had 2 patients delisted after Sotatercept initiation because they just don't need it anymore. Live like this. So it's not obsolete, but it's getting there. That's all I have.
A really good presentation, right? That's one of the best that we had this year. So
Thank you.
I think, unfortunately, there might be a meeting here, so there's not much room for question and answer, but you will continue in the fellows room now for a conversation with the fellows. I just wanted to ask you one question. As a chief, I have that.
Yes. You're allowed.
So you presented a case of exercise testing in the cath table, and it caught my attention that you measure the changes in PA pressure, but you didn't report cardiac output of
Yeah.
PVR. Do you need that? I mean, I think that clearly was a patient of HFpEF, but could it be in a patient that has exercise-induced MR,
Sure. And this is,
ischemia?
yeah.
Or possibly could it be type 1
Yeah.
pulmonary hypertension that we don't know unless we get the PVR?
Yeah, and I think that's a really important point, which is why I think this is the way we do it in the cath lab, not the right way. You need to have a mechanism to measure cardiac output with exercise, and this is what these fancy labs with these CPET testings and invasive hemodynamics do, where it's almost impossible to get a cardiac output. The FIC is not accurate because, yeah, they perhaps, yeah, just to say guardians.